I am Chris Baker, and today I'd like to show you how I craft medical case studies for my high school students. The goal is to get them to move from gathering information about patients to being able to offer up a potential diagnosis and treatment plan. So the goals when I teach medical anatomy and physiology are such that a student will be able to obtain a history and physical, and we'll go over what a history and physical is in more detail in a little bit. Then develop a differential diagnosis, a list of different diagnoses that could possibly be causing the problem that our patient is experiencing. Then order the appropriate diagnostic tests to narrow down the differential diagnosis, interpret those test results, and whittle everything down to one clinical impression. Then propose a treatment plan. So, how do we do this? Through clinical case studies. When I build my case studies, I craft each of them to help students make connections between all the different parts. So, for example, the chief complaint and the history of present illness or mechanisms of injury, and review of systems, past medical history, medications, and physical exam findings must all be connected in some way. So if the chief complaint, for example, is abdominal pain, the history of present illness could be sudden onset of right lower quadrant abdominal pain, nausea, vomiting, and a fever. Review of systems might be nausea, vomiting, abdominal pain, fevers and chills over the past 2 days. Past medical history might not be significant. Medications need to be related to past medical history. So if they do have a past medical history of, let's say, diabetes, they need to be on medications that help control diabetes. And a physical exam findings all need to tie in as well. So here are two examples to help illustrate my point. Example number 1, shortness of breath. We've got a 22-year-old female whose chief complaint is chest tightness and shortness of breath. This occurred suddenly after eating at a buffet. She is complaining of nausea, vomiting, dizziness, chest tightness, wheezing, and a rash. Her past medical history is significant for anaphylaxis due to a peanut allergy. She carries an EpiPen and uses Benadryl as needed. Physical findings are pallor, tripoding, wheezing, urticaria, and hypotension. The most likely clinical impression that students should be able to come up with is anaphylaxis, given the above abbreviated or shortened history and physical. Here's another example. Another 22-year-old female, again with chest tightness and shortness of breath. But this time, the onset was sudden after a 12-hour transcontinental flight. She also has chest tightness and dyspnea. For past medical and social history, she's a smoker. For medications, she takes oral contraceptives. Her physical findings are almost the same. She has pallor, she has dyspnea, she is hypotensive, but she has clear lung sounds. So in this case, the clinical impression should point towards pulmonary embolism due to the abbreviated history and physical. So let's compare the two. Both 22-year-old female with chest tightness and shortness of breath. Whereas one has an onset after eating at a buffet, the other has an onset after a 12-hour long flight. Nausea, vomiting, dizziness, chest tightness, wheezing, and a rash. Chest tightness and dyspnea for her review of systems. A little different there. Past medical history of anaphylaxis versus smoking social history. EpiPen and Benadryl as needed, whereas oral contraceptives. Physical exam is almost identical, except that the woman experiencing anaphylaxis has wheezing, whereas the woman experiencing pulmonary embolism has clear lung sounds. So therefore, there are little nuances, there are little clues throughout both of these scenarios that should point to anaphylaxis in case number 1 versus pulmonary embolism in case number 2. So how do we organize this? How do we organize our learning? Well, let me show you. I'm going to show you an example of a history and physical form that I've come up with over the years in OneNote. So this is an example of a history and physical form that I use and that my students use, primarily my students use, to record information when they interview a patient and obtain a history and physical from a patient. In those cases, that would be me. So this form I created over the series of several years. There are many iterations of it, and it is a blend between pre-hospital EMS and an emergency department history and physical form. I tried my best to keep the level of fidelity and medical terminology, the bar set pretty high. So this way, when my students do graduate high school and go into undergraduate, if they're going into nursing or PT or OT or some sort of medical postgraduate program, they will be used to and they will have been exposed to this medical terminology. So let's start off here. We've got the patient name, age, sex, weight. They need to be able to convert from pounds to kilos. The section here, the first section is primary survey. We go over scene safety. The scene survey, looking for clues. Skin color. Does your patient look remarkably pale or flushed or cyanotic? Level of consciousness using the AVPU scale. Circulation and bleeding. Do they have a pulse? Yes or no? Is there major bleeding? Yes or no? Is their airway intact? Yes or no? Are they breathing adequately? Yes or no? If there are any problems with any of those factors, they need to be fixed immediately within the first 30 seconds of patient encounter. Then we come down to chief complaint and history of present illness or mechanism of injury. Mechanism of injury is for trauma. History of present illness is for medical. I try to keep those separated. You have to remember, this is 11th grade and 10th grade and 12th grade high school anatomy and physiology. So I don't want them to be too confused. So next is review of systems, and these are all the typical review of systems that we check off. If there is anything that is abnormal, that would be on the right-hand side column here. And if there's anything that gets checked off there, the student must elaborate. So for example, if they ask me, do I have fevers or chills? No. Next question, do I have any headaches? No. Next question, have I experienced any recent weakness? Yes. They now need to follow that rabbit hole and ask me about my weakness. When does it occur? Does it occur early in the day, end of day, throughout the day? Are there any alleviating or aggravating factors? Okay, and so on and so on. So this is the whole review of systems. Then we get to past medical and surgical history and medications, over-the-counter and prescription, and allergies to medications. And what I typically, when students are obtaining a history and physical from me, I typically do not give them my medical or surgical history, or the patient's rather. But what I do instead is I give them the medications I'm on. So I might say I'm on these 3 different medications. Well, they need to look it up and determine what my past medical or surgical history probably is based on those medications. They need to match up exactly. The reason I do that is because we sometimes encounter unconscious patients that cannot talk to us, or the family members do not know the medical or surgical history. So we have to do detective work and look at the medications and work backwards. Tetanus, last menstrual period, social history. Next section is now that's it for the history portion, which is all subjective. Now we are to the objective section of the physical exam, specifically vital signs. 5 vital signs there. Physical exam, as far as the secondary survey goes, is the patient sick or not sick? Examine the skin for color, temperature, rashes, head, ears, eyes, nose, throat, pupils, ears, nose, throat, neck, chest, cardiac, lungs, abdomen, musculoskeletal, extremities. Okay, then what we do is we fill out our forms and we circle the odd or unusual or anything that really sticks out in history and physical. And then my students will then come up with a differential diagnosis. And we'll get to this in a second. Actually, I've got an example I'm going to run through with you. Okay, so we'll come back to this in just a few moments. So, how do we craft a case study from scratch? We might have some clinical impressions or diagnoses that we want our students to learn about, like heart attack, appendicitis, acute asthma, something along those lines. But how do we do it? Well, I found out if we start with a diagnosis and we work backwards, we can create the case systematically. So if we look at our history and physical exam, we need to connect the dots between a bunch of those different parameters to really build a solid case. Okay, so let's start with chief complaint. We have to figure out what would the chief complaint most likely be for that diagnosis that we're working toward. How would the history of present illness or mechanism of injury support that? How would the review of systems support that chief complaint? So for example, we might have a lead actress, but there are supporting actresses or supporting actors in the background helping to fill in the gaps to make a really good story. So that's where the review of systems comes in when we craft our medical case study. What kind of past medical or surgical history would lead to this issue? So for example, if we're thinking about a hemorrhagic stroke as our final diagnosis, it would probably be a good idea to have hypertension or hypercholesterolemia, hyperlipidemia as part of our past medical history to help support that. The medications that our patient is on need to match up with their past medical and past surgical history. Vital signs. We need to think about the vital signs. So if our patient, let's say, has a collapsed lung, in a car wreck, collapsed lung, they're most likely, if they have a tension pneumothorax, they're going to be hypotensive. Well, how does the body respond to hypotension? Heart rate times stroke volume times peripheral vascular resistance equals blood pressure. When you become hypotensive, your heart rate, stroke volume, and peripheral vascular resistance each kick up in order to compensate for that hypotension. So therefore, their heart rate should be high, stroke volume should be high, and peripheral vascular resistance should be high. If their peripheral vascular resistance is high, one of the physical exam findings that must be consistent is that their skin must be pale. For patients with a darker skin complexion, we don't have to look at pallor on the exterior. We can pull down a lower lip and look at the mucous membranes for pallor. Okay, so it's very important that the vital signs correlate with the rest of the parts of the puzzle as well as the physical exam findings. Then we need to anticipate what students are going to come up with as far as the differential diagnosis. They might come off with some off-the-wall stuff, but as the weeks go on, they will become more disciplined, or more focused, or more able to make those connections as we do more and more cases. Students are then going to be asked to propose diagnostic tests to rule in or rule out each of those differential diagnoses, and look at the test results, and we help them interpret the test results and what are the normal ranges, what's abnormal, and lastly, what's the appropriate treatment plan for this diagnosis. So now let's take a look at a way to organize all this information in a spreadsheet. Okay? So here's the master spreadsheet that I use to organize all my data. On the left-hand column here, column A, we have 19 different diagnoses, ranging from myocardial infarction to asthma, right-sided congestive heart failure, left-sided congestive heart failure, hypoglycemia, ischemic stroke, and on and on. Okay? In the next column, column B, I have the associated chief complaint. So for example, 63-year-old with pulmonary embolism, their chief complaint will be shortness of breath in the case that I created. History of present illness for that same patient will be shortness of breath and heart palpitations for a few hours. Their past medical history will be atrial fibrillation. Because they have AFib, they will be on cardizem and Lanoxin. Now these fit in because atrial fibrillation puts you at a higher risk of throwing a clot either from the right atrium or the left atrium. And cortisone and lanoxin are both used to help control atrial fibrillation. Well, if you throw a clot in the right atrium or the left atrium, they can then end up in either the pulmonary circulation or the systemic circulation. Okay, the patient will look, general appearance-wise, will look ill. Skin color is going to be pale. They'll be alert, and on and on and on. I simply type in all the different parameters here, going from left to right. Ending up with a treatment plan. You can see along the top are all the treatments, the treatment and the diagnostic tests. Okay, so that's where I put my data. That's how I organize. So let's take a look up here at myocardial infarction. So this is a 45-year-old with chest pain, history of present illness, chest pain for several hours, shortness of breath, and left arm ache. Past medical history of hyperlipidemia. Patients on simvastatin and Lipitor. They look ill. Their skin color is pale. They are alert. They have a good pulse that's easy to find. They're speaking normally, so they have an airway, and they're breathing fairly normally. Blood pressure is stable at 120/80. Pulse is 70. Respirations are 14. Pulse oximetry is 97%. Temperature is 98.6%, 98.6 degrees Fahrenheit or 37 degrees Celsius. Pupils are pearl, chest is non-tender, lung sounds are clear, abdomen's not non-tender, full range of motion at all four extremities, no pedal edema, fingerstick glucose is normal, chest x-ray is normal. There's no need for an abdominal ultrasound, there's no need for a head CT, there's no need for an abdominal pelvic CT. Blood work shows elevated cardiac troponin, which is a sign of cardiac injury. EKG indicates an ST segment elevation MI or STEMI, in other words, a myocardial infarction. There's no need for a VQ scan, and the treatment for a STEMI is cardiac catheterization and subsequent angioplasty. Now that you have an idea of how I organize my data, let's actually build a case together. We're going to build a myocardial infarction case. Okay, let's build this case together. Let's start off with myocardial infarction as our clinical impression. That's the diagnosis that we want our students to be able to come up with at the end of this exercise. So we're going to start with the diagnosis of MI and work backwards systematically to create the case. So somebody complaining of chest discomfort may be having a myocardial infarction. That would be their chief complaint. As far as history of illness or mechanism of injury, we could say, how about a sudden onset of symptoms after shoveling wet, heavy snow? We're trying to paint a picture here, okay? Review of systems that are supporting this diagnosis would be trouble breathing, left arm ache, nausea, vomiting, weakness, near syncope, okay? Past medical history that could contribute to experiencing a myocardial infarction could be high blood pressure, high cholesterol, and diabetes. The medications that would match up with high blood pressure, high cholesterol, and diabetes could be Vasotec for hypertension, simvastatin for hyperlipidemia, and Januvia for diabetes. Vital sign-wise, so let's say our blood pressure is 90/50. We really have to tie in the rest of the vital signs for this to make sense, okay? So if our blood pressure is 90/50, that means we're hypotensive. That means that heart rate times stroke volume times PVR is equal to blood pressure. That means our heart rate should be elevated, our stroke volume should be elevated, and our peripheral vascular resistance should be elevated. So therefore our heart rate is 110, which is elevated. Our respiratory rate is slightly elevated. Pulse ox is good at 97%, and temperature is at 37 degrees Celsius or 98.6. So we'll see about peripheral vascular resistance in a minute. So when we look at skin color, let's say this person is Caucasian, and we want to match the skin perfusion to the peripheral vascular resistance. Well, if they're hypotensive, that means the resistance is going to be high. That means they're shunting blood to the core of their body. That means they're going to appear pale. In addition, we added diaphoresis. So now the kids are going to come up with differential diagnosis, okay? So some might say heart attack right off the bat because grandma had a heart attack last year and she had nausea, vomiting, left arm ache, and this is like classic heart attack, okay? Some other students might come up with pneumonia, might come up with bronchitis, asthma. There are any number of differentials that they might come up with, but we need to anticipate those. That's the thing. As far as diagnostic tests to rule in or rule out each of these on the differential, chest x-ray, electrocardiogram, lab work. So we'll need to know what those test results are going to be. So in this case, the chest x-ray is going to be normal. Troponin, cardiac troponin is going to be elevated in the bloodstream, and our EKG is going to show an ST segment elevation, myocardial infarction, or STEMI. And the treatment plan for that is oxygen, IV, anticoagulants, and a trip to the cath lab. Now, let's take a look at how we can fill out a history and physical form to paint this really good picture. All right, let's build our myocardial chest pain case study from scratch. Okay, so I chose a patient, 65 years of age, male, 180 pounds. The students convert that to kilos because all medications are weight-based. Primary survey, the scene is safe. There is scene survey or clues, heavy wet snowfall. When they first encounter the patient, he is pale, he is alert, he has a radial pulse that is present, there's no obvious bleeding, he is speaking so his airway is patent, and he is speaking so he is breathing adequately. His chief complaint is chest discomfort. When you ask him what brought upon his chest discomfort, he says he was shoveling wet, heavy snow for the past few hours this morning. He felt lightheaded, came inside, and started to become dyspneic. As far as review of systems, and I'm going to go quickly here because you can pause and you can rewind this video. As far as review of systems, he has no fevers or chills, no headache. He is lightheaded. He has not syncopized, no visual changes, hearing loss, or sore throat. He does have chest discomfort described as the front of his chest, 6 out of 10, and he describes it as pressure. No palpitations, but he does have trouble catching his breath. Okay. The rest of the review of systems, other than a few down here, is negative. He's got waves of nausea, and as far as muscle, bone, aches or pains, he does have left shoulder and left arm ache. Okay, his past medical history is hypertension, hyperlipidemia, and non-insulin dependent diabetes, for which he takes Vasotec, Simvastatin, and Januvia. And as I said earlier, these need to match up. So Vasotec for hypertension, Simvastatin for hyperlipidemia, and Januvia for diabetes. No known drug allergies, unknown last tetanus, not applicable last menstrual period. He is a 1-pack-a-day smoker. These are his vital signs as discussed earlier. Heart rate of 110, hypotensive at 90/50, respiratory rate of 20, 97% pulse ox on room air, and 37 degrees Celsius normal temperature. So as far as physical exam goes, secondary survey, he's sick, he's ill appearing, his skin is pale and diaphoretic, head, ears, eyes, nose, throat is normal, all the way up until we get down to, that's it. Okay, everything else is normal on the physical exam. Okay, so now, oh, by the way, I have a spot over here for folks to diagram anything that they find on their physical exam. All right, so let's go back over here. Okay, so now to anticipate the differential diagnoses the kids might come up with, we think, okay, heart attack, pneumonia, bronchitis, asthma. So we need to anticipate a couple of those. Some of those might come out from left field. That's okay, we'll work with those. But here's the thing. In order to get the kids to come up with these differential diagnoses, I have them go back and I have them circle anything abnormal in the findings. So let's do that together here. Let's go to the very top here, and we're going to go with red. Okay, so things that really stick out here. Okay, he's pale, so here's some clues. Heavy, wet snowfall, chest discomfort. Anything in history of present illness is important. Okay, lightheadedness is important. Chest pain or discomfort in the front of the chest, describes it as pressure, trouble catching breath. 6 out of 10 pressure. Nausea coming and going in waves, left shoulder and arm ache. Okay, these are some risk factors here for myocardial infarction. So is smoking, pack-a-day smoker. All right, his pulse rate is elevated. Should be between 60 and 100 beats per minute. This is a little fast. He is certainly hypotensive. Respiratory rate is a little elevated. Pulse ox and temperature are normal. Other significant findings, he looks sick. You come around the corner and you see this guy and you're like, ooh, you don't look so good. Okay, so he's ill-appearing. Pale, diaphoretic skin. Okay, so what I have them do as they do the case in class is come up with the justification for including, why do you think it's a heart attack? Why do you think it's pneumonia? Why do you think it's bronchitis? Why do you think it's asthma? Okay, I try to make them think and not just guess. Okay, then we brainstorm as far as the kind of tests that probably should be done. So fingerstick glucose. Patient's complaining of weakness. He has a history of diabetes. Probably should check a blood sugar on him. Well, that's normal. That's 89 milligrams per deciliter. We do a 12-lead EKG or ECG, and whoa! ST segment elevation in leads, V3, 4, 5, and 6. Reciprocal ST segment depression in leads 2, 3, and AVF. That's leading towards an MI. That's screaming MI, actually. Blood work is positive for cardiac troponin, and that's elevated, and the white blood cell count is normal. Chest x-ray is clear. Okay, that's it for the diagnostics. So now we can actually go back and we can cross off pneumonia because the chest x-ray is clear, and they would put it over here, justification for excluding. The chest x-ray is clear, white blood cell count is normal, and they're afebrile. For the same reason, we can cross off bronchitis. In addition, the lung sounds were normal. When we go back up here, lung sounds were normal. Okay? And for that reason, we can also cross off asthma. His lung sounds are normal, chest x-ray is normal, everything's normal so far. So this is all pointing towards heart attack, in which case they would then write down here their clinical impression is heart attack due to the chief complaint, history of present illness, review of systems, past medical history, medications, physical exam, the 12-lead EKG, chest x-ray, and lab work. And we will discuss how to treat a heart attack. We will discuss what a heart attack is right there on the spot, discuss what it is, and talk about how it's basically a major plumbing problem and how do we fix clogs in plumbing. All right, so oxygen, aspirin, IV, pain control, and cardiac catheterization. Okay, so now let's flip the script. And I tried this with my last semester students, and it worked phenomenally. Instead of me presenting a case to them and them asking all the questions of the history portion and obtaining all the information for physical exam and coming up with a differential diagnosis and clinical impression and treatment plan, I flipped the script on them and I said, okay, I'm going to assign each of you a diagnosis and you're going to build your own case study. Wow. Well, how did I manage to do it with my students? Let me show you. So here's the master sheet I have of the 19 cases that I've built. Okay, so like for example, for a right-sided congestive heart failure, the chief complaint is going to be swollen ankles, history of present illness, swollen ankles worsening over the past 2 days, past medical history of a past heart attack, and this patient is on diuretics, Lasix and Bumex. Okay, and they look normal, general appearance. They don't look super sick, right? Okay. versus the left-sided CHF patient is complaining of shortness of breath, short of breath for a couple hours, can't lay flat, so orthopnea. Again, past medical history of a heart attack, again, is also on Lasix and Bumex, both diuretics, but this patient is ill. All right, so how do I take all this and how do I have a student build their case study from scratch? Well, it's not really from scratch. So what I do is I provide them with a fixed price or a prefix menu, and I'll show you that in just a couple minutes. Just bear with me here. So check this out. I have 3 tabs on the bottom here, 3 separate sheets. So what I did was I took all the choices that were, let's say, in chief complaint. You'll notice there's chest pain, shortness of breath, swollen ankles, shortness of breath, decreased level of consciousness, headache, decreased level of consciousness, shortness of breath. There are a lot of repeats. So what I did was in the next sheet here, I sorted these alphabetically. Okay, so choices here: headache, shortness of breath, shortness of breath, shortness of breath, shortness of breath. Okay, now you'll notice that these are all sorted. Each of these columns, not A, column A that has the final diagnosis is still cemented as is there. Okay, but the rest of these are all alphabetical. Okay, past medical history: alcoholism, Alzheimer's, asthma, AFib, all the way down. Okay, so now I don't want you thinking that these match up with the diagnoses on the left, because the reason I made these alphabetical is because here in the third sheet, what I did was I took repeats. So for example, here's AFib, and I deleted the repeats. So here we are in that third sheet. There's only one atrial fibrillation there. There's only one asthma. Okay, there's only one chronic back pain, only one diabetes. Because if I did do that, it allows me to easily cut and paste this into some sort of format where I can make it a checklist for the kids to check off. You'll see what that means in a minute here. So check this out. For example, general appearance, the kids only have 2 choices when they build their own case study. So let's say the student's been assigned either myocardial infarction or asthma or right side CHF, left side CHF. Doesn't matter what it is. The only 2 choices they're going to have for general patient appearance are ill or normal. The only 4 choices they're going to have for skin color are cyanotic, jaundiced, normal, whatever normal is for that patient, or pale. Okay, so there are no duplicates here, and what that means is that we can make drop-down boxes or we can make choices on that prefix menu very easily. Let me show you what that looks like right now. So here's where I have students build their own case study as one of their final summative assessments. Okay, so they type in here or handwrite in, because we use OneNote at our school district. They can write in the clinical impression that they've been assigned, whether it's heart attack or whether it's left-sided CHF, right-sided CHF, whatever it is. Okay, and there are 30 parameters here that I've picked. Those are the 30 parameters that are in the spreadsheet that I just showed you, that all come from the history and physical form. Okay, so remember, we're working backwards here. Students know that they have a final diagnosis. So for example, for skin color, they have to pick what skin color does their patient look like, which they exhibit. And they have to give a reason that choice is picked. So for example, if they're in their scenario, let's say it is a lacerated spleen and they pick a blood pressure of 90/50, they should really pick a pale skin color, because when you have hypotension, heart rate, and stroke volume, and peripheral vascular resistance all increase in order to bring that blood pressure back up to normal. So therefore, with high peripheral vascular resistance, you're shunning blood from the skin to the core, the patient turns pale. So they need to articulate why they picked pale. Okay, and this is where that spreadsheet where I put all the different components in alphabetical order and then I deleted the duplicates comes in handy, because these are the only 4 choices for skin color they have, the only 4 choices for level of consciousness. For circulation, they only have 2 choices. The patient either has a good pulse or they have a weak pulse. I don't have any cardiac arrest scenarios in in my case studies. So everyone either has a good, easy to find pulse or a weak pulse. Okay, I'll skip a couple here. Here we go. Chief complaint. So now, for example, one of my diagnoses is appendicitis. So they really should select right lower quadrant pain. Okay, versus a hepatic injury, in which case they would need to select right upper quadrant pain, versus a splenic laceration, left upper quadrant pain. Okay, so this is where making sure all those connections are in place and crafting your cases carefully comes into play. Same goes with history of present illness. So, for example, somebody with right lower quadrant pain and nausea for several days, that fits into the appendicitis picture. Okay, versus down here, swollen ankles worsening over the past 2 days. Boom, that's pointing towards right-sided CHF, right-sided congestive heart failure. Tearing sensation, okay, if it's in the umbilical region, probably a AAA. Tearing sensation in the upper back and the thoracic region, probably dissecting thoracic aneurysm. Okay, and all of these are all connected. And again, I think the most important part is for the students to articulate why they picked that particular choice. Because if their choice is incorrect, but they articulate a physiologically sound argument for why they picked it, okay, that works for me. It's the thinking part of it, not the memorization. It's the thinking part, the clinical decision making that I'm really after. Okay?